Hello everyone and welcome to Kennedy. Today I have the honor and pleasure of interviewing Chad Cook, physiotherapist, professor, clinical researcher with a great significant experience in the field of manual therapy. In this episode, Chad Cook will talk about the role of manual therapy, its position in the field of physiotherapy, the research he's conducted on manual therapy and the results he's found, and what the future holds. Hello, Chad. Thank you so much for joining me today.
Thank you so much for having me on. I'm very excited to talk with you.
Yes, me too. We're going to talk about manual therapy and your research on manual therapy, mostly. But first of all, could you tell us a little bit about yourself and tell us also what made you want to specialize in that area and also what do you do today?
Okay. And I'll try to keep it brief. I have been a physiotherapist for 34 years. I currently am in the United States in a state called North Carolina, and I work at Duke University. So I'm primarily an academic researcher, but I do actually practice 2 days a week. I started in 1990 as a general orthopedic physiotherapist, and I worked for an organization that was interested in training their PTs to be manual therapists. They wanted to specialize in that area, and I volunteered. So I took a number of different courses and eventually became certified in the Maitland approach, which is an Australian-based approach, and then began teaching that as well in about 1997, I think. It's grown from there. I've taught probably 250 to 300 courses in over 40 countries and have done a lot of research in that area too. And I don't only do manual therapy, but it's certainly an area that I'm interested in and passionate about.
What do you see that has changed mostly in the teaching methods from the time where you were a student and nowadays as a physiotherapist?
I think a lot has changed, especially in the early 90s when I was training. We were taught a very rigid, philosophical-based method, and depending on which approach you actually learned, and I took a lot of different approaches, the Nordic approach, more of an Australian approach, a general European approach, and they were all very different, and they were all very anchored to different philosophies, and you didn't veer away from those philosophies. It was very dogmatic. It was not based in evidence at all. It was primarily based in what people felt was happening, and they basically used the best science they had at that time, which wasn't very good. But it was, again, very dogmatic, very rigid, very structural. You spent a lot of time learning how to do specific techniques. Nowadays, I think it's very different. We try to anchor it toward what the evidence suggests. We know that the techniques do not need to be as rigid and specific as we once thought. There's greater flexibility, and there's, I think, a better understanding of what it does and doesn't do.
Yeah, very interesting. Yeah, just to go back on the Maitland technique, you said you still teach it nowadays?
Not the Maitland technique, no.
Not the Maitland technique.
When I teach now, I'll teach an eclectic approach. I will say that I'm very influenced by Maitland's assessment process, which I still think is quite brilliant and very patient-centered, very person-centered. So that part of it I still use, as many approaches I think use a Maitland assessment process. But I've moved on from some of the more philosophically driven components of Maitland and have adopted different approaches.
Okay. In your own words, what differentiates the Maitland technique approach to, for instance, Mulligan or Mackenzie?
Yeah, so I think the Maitland and Mulligan approach, assessment-wise, are probably identical. I think the difference between Mulligan and Maitland is application and a willingness to apply pain to their patient. Maitland tends to work in the pain. Mulligan tends to be pain-free when they perform their particular approaches. Most of the other approaches are very biomechanical based. So a lot of the Nordic approaches, etc., very arthrokinematic driven. You have to move along with the principles of roll, spin, and glide, and convex on concave, and another number of other areas. They're very specific in the way that they apply their interventions. It tends to take a longer time, I think, to master those. So quite a different pathway, I think, from the Maitland approach, which is very driven by the patient. And I think the biomechanical approaches are very driven by the clinician.
Interesting. Mm-hmm. Now, to talk a little bit more about yourself, how do you organize yourself on a weekly basis with your research, your teachings, and your practice?
Well, I'm in academia, so there are some areas that I'm responsible for, such as teaching or meetings related to grants or something like that. But other than that, there's a great deal of flexibility, which I think is one of the things I love so much about it. There's a lot of time for creative thinking and reading and really not being bogged down with a lot of things that clinicians are responsible for. Tuesday and Thursday are the days that I actually treat patients, and I treat the patients in our trials. So I want to make sure that the care provided is what I think is quality care. So I tend to provide the care in my studies. I think fidelity is a big problem with a lot of the research studies that are out there. Because I'm in a primary research position, I have to write a lot of grants. And your listeners may not know this, but there is probably 75 to 150 hours that go into every grant that an academic writes.
That's a
So
lot.
it's a lot. So it takes a lot of time. It's a whole lot of material, and a lot of time is spent on that. And interestingly enough, success rates for getting grants are very low. A successful awardee will get maybe 10% of the grants they submit. So you work very hard for little gain on that.
When you talk about grants, just for our listeners, because it's slightly different system in France, for instance, is it PhD students that we're talking about, or students in general?
No, my apologies. I'm very U.S. centric. When we talk about grants, it's the government and sometimes private foundations will actually put a call out for research in which they'll say, we'll give you $1 million if you do a certain type of study. And especially with the National Institutes of Health, or NIH, they tend to have over billions of dollars of US dollars in grants each year that researchers will apply for. And those grants will pay for the research, because research is really expensive to do. Mm-hmm. And those grants will pay for your time. They'll pay for any of the equipment that you need. They'll pay the patients to come in. They'll pay for the statisticians and the regulatory aspects and that sort of thing. So we're very lucky in the United States that we have a formal granting system, mm-hmm. But it's very competitive. It's challenging, but it does. That's what I mean by when I say grants.
Okay, yeah, interesting. Yeah, slightly different system. So let's talk about manual therapy now. To you, what are, and a very broad definition, what are its advantages and its inconvenience as a physiotherapist?
Yeah, I think, first of all, that's a good question. And I'm going to answer it several different ways, because I think you have to almost surround it to really understand it. I think manual therapy has suffered from a lot of bad definitions in the past, and a lot of weird things that people call manual therapy, like craniosacral. I don't think that's manual therapy, or Reiki, or any of these things that they're called manual therapy, but I don't think they really fit the realm that we want. So I would describe manual therapy as skilled therapeutic use of the hands. So I don't think dry needling is manual therapy. I don't think instrumented massage is manual therapy, but mobilization, manipulation, soft tissue mobilization, and muscle energy techniques, I would throw those into that skilled application of the hands. We did just publish a definition of orthopedic manual therapy in the Journal of Physical Therapy and the lead author is Jason Silvernail. So if your listeners are interested in looking at our definition, and I think what's essential is it's not a standalone intervention. In our minds, manual therapy is an integrated approach that uses clinical reasoning, and there is always an active component baked in. So it isn't, us just doing manipulation on people and nothing else. It's not just application of techniques, which we don't think is sophisticated enough. It has to have a reasoning behind it. There needs to be a purpose behind that intervention, and it needs to be skilled with some element of training baked in.
Yeah, and that brings me to my next question. To you, what constitutes a good manual therapist?
Well, I think it might surprise you the way I answer this, but I think the same things that make a good manual therapist are the same things that make a good physiotherapist, and that is a very person-centered, empathetic, caring individual who does their best to really understand the patient's needs and meets the patient where they're at and applies the right treatment for that particular patient. And the right treatment may be different from person to person. So a good manual therapist may use manual therapy sometimes they may not. A good manual therapist will be the type of individual whose care will look a little different depending on what that patient's needs are. So it's a very adaptive clinician who really does care about their patient, really cares about the intervention that they provide. And to me, that's not a whole lot different than a good physiotherapist.
Mm-hmm.
I think the selective elements that may distinguish a really good manual therapist is that they've had a lot of experience. They've seen different patterns of problems with patients, of musculoskeletal problems that they can address that maybe have failed in other clinicians' hands. And I've seen a lot of those out there. There are really talented clinicians who just seem to have a gift on that end of it. But that gift isn't something supernatural. It's something that is earned through a lot of training and a lot of patient interaction.
Mm-hmm. Yeah. So you talked about it a little bit, when to use manual therapy, when is the best for a particular type of patient. But is there a good way to know when to use it and for what type of patient or pathology, whether it's persistent pain or acute pain or...
No, I appreciate the question because especially with precision medicine looming and the hopes that we can actually provide the right care for the right patient at the right time, I will start by just saying we don't know yet. We don't have the ability to understand what patient in front of us needs a particular intervention. We don't know if they need exercise. We don't know if they need manual therapy. We don't know if they're going to benefit from cognitive behavioral therapy. There's such variability in the studies that have looked at this, that have looked at treatment effect moderators, and we just don't have that down yet. We don't even have that down for surgery or medications or whatever. We're still working on it, and that's certainly the holy grail of what we do. Consequently, we do our best, and we clinically reason, and we look at selective features of that patient. And I'll just walk through a couple of things that I look for in a patient population. First of all, it's a patient preference, a patient expectation that they're going to receive manual therapy. They want it. They've had it before, or they believe it's something that might be beneficial for them. Contextually, that will have some benefit for that patient. Pain mechanisms probably matter. If they have nociceptive pain mechanisms, they probably are going to be more responsive to manual therapy than nociplastic. Nociplastic probably need a better or a different type of intervention. Neuropathic, you probably need to alter your manual therapy approach quite a bit and the intent of it, but it can still be beneficial too. The last thing is musculoskeletal wise, if individuals have stiffness, if they have selected regions that are blocked in the spine or in the periphery, if it's unidirectional, if they've got a primary pain problem, they tend to respond to early manual therapy integrated with an active approach, in my experience. But certainly you would apply and see if it makes a difference. If it doesn't, move on to do something else.
Mm-hmm. Yeah. Mm-hmm. Regarding the technique of manual therapy, to go into detail here, is it important to be precise in the hand placement, or actually with retrospect, research has proven that it doesn't really matter exactly if the hand is not exactly where it should be, that the message, the response of the patient is going to be positive, is going to send a positive message in the body?
Yeah, great question. And because especially with the amount of time that manual therapists put into the specificity of training and the education of it, it makes you matter. Do we need to be precise in the way that we educate? So let me walk through the literature on that, because there's literature, there's not near as much literature in that area around the periphery, but there's quite a bit on the spine. There are 9 randomized trials that have looked at spinal manipulation on whether or not it needs to be specific. And I believe there are 6 on mobilization. The spinal manipulation studies show that when you look at the average treatment effects of a precise or specific group versus a non-specific group, that there's no difference in the average or mean outcomes between those two groups. Now, in any RCT, there are some people that really benefit from that intervention. There are some that don't. And what you see is pretty widespread among those 9 studies. There are some people that benefit from a precise approach, some people who don't, but there are also some people who benefit from an imprecise or a non-specific approach, and some who don't. But on average, there's no difference between those two groups. So on average, we would say, no, you don't need to be specific, especially when you're looking at pain and disability. Now, when you look at global rating of change, there are 3 studies that actually have said that you should be specific. The difference with the global rating of change is its perception of the patient. So it's probably a contextual component. Patient thinks there's something because you're on their particular area. They think they're getting something more valid from that. With mobilization, interestingly enough, there are actually 2 studies that suggest that a non-specific approach may actually be better than a specific approach. So that's quite interesting. And that's for pain and disability.
Yeah, that is interesting. Mm-hmm. Yeah.
So if I could summarize that, certainly right now, based on the literature we have, and if we're looking at outcomes of pain and disability, then the very dogmatic, rigid application of a specific approach is not supported. However, there may be some patients that you work with that would benefit from a specific approach, and that's up to a clinician to ascertain. Probably things like cervicogenic headache would fall into that, and then potentially some areas around the neck. I don't think you need to be specific at all with the back. A general manipulation, non-specific manipulation is probably beneficial. It doesn't seem to be that you need to be specific around the shoulder, although the shoulder does suggest a specified approach will give a significantly higher grok as well. So again, it depends on what you measure, and it depends on the interpretation, I guess.
Mm-hmm. Okay. So in regards to teaching and training, what would you recommend to a physiotherapist who want to train in manual therapy?
So the real challenge is the psychomotor aspect of training someone to use techniques takes a long time. And because our scope of practice has widened so much, that it competes a lot with a lot of the other skills we need to learn as physios. I mean, think about how much the profession has changed over the last 2 decades. So in an educational setting, we have to decide, should we be spending so much time on the specificity of techniques and teaching all of these things, or should we cut that down to maybe a few techniques, maybe talk a little bit more about, what should you say to a patient? How do you frame manual therapy? What are you looking for? What is a good response? And my answer to that is yes, spend more time on that part and understanding what the response should look like, and maybe cut down a little bit on learning 8,000 different techniques that do very specific things and learn more general approaches. That's been our approach, especially with how challenging it is time-wise. And I think we also need to know your audience, right?
Mm-hmm.
Sometimes when you teach, the people are functioning at a much higher level, and you can get into more philosophical discussions, more understanding, more reasoning, more treatment around pain mechanisms, that sort of thing, than being very basic and spending a whole lot of time in the lab on techniques.
Mm-hmm. Yeah. Yeah. Does make sense. Yeah. Um, Manual therapy, according to your research, does it work better for persistent pain patients rather than acute pain patients? Or what does the research say regarding that?
So it's interesting. It depends on how, for example, persistence pain is described.
Mm.
So I had this discussion recently with an individual when they looked at the IASP definition of primary chronic pain. That is a very wide umbrella, and it covers things like irritable bowel syndrome and organ problems and chronic musculoskeletal problems. So for IBS and organ problems and stuff like that, no, manual therapy is probably not going to be beneficial at all with that. For selected chronic pain conditions like chronic low back pain, chronic neck pain, it actually does fairly well in the literature. It does as well or superior to comparative interventions. Now, it does well on acute or subacute conditions too, but in many cases, those will self resolve. So, in essence, you don't see as much value in it because it's likely the prognosis is going to be good anyway, and most likely any intervention would be useful in that particular case. But I think there's a misconception that there isn't literature to actually support manual therapy for chronic persistence pain.
Mm.
It actually does fairly well with that as an integrated element along with an active approach and a talk-based approach. And if I could, and I know I'm going on and on, but I think it's really important. I'm a database researcher, so I will get data sets that have 150,000 patient visit or 150,000 physical therapists patients that have been seen. And there is almost never an instance in which manual therapy is the only treatment used. It's almost 99.7% of the time, it is integrated in with an active approach. So the physios in those data sets, and these are American-based physical therapists, they don't use manual therapy by itself. And that's been a big complaint about manual therapy. I think it's a silly complaint because I don't think therapists just use manual therapy. They use it as an integrated approach.
Mm-hmm. Mm-hmm. Yeah, you were talking about persistent pain patients, chronic pain, and you said that manual therapy has proved to be efficient. There's a whole biopsychosocial aspect to the persistent pain, right?
Yep.
And I guess that their manual therapy has an important place in the sense that those people live with their pain, and there's a big psychological aspect to it probably as well. Do these people want to be touched more than people who are in acute or subacute pain? Probably, right?
That could certainly be part of it.
Mm-hmm.
Absolutely. So one of the areas that we've researched, and I didn't mention this, but I actually have a certificate in chronic pain management through McGill. So I did additional 2+ years of study to better understand how to manage patients with chronic pain. And I work with a lot of psychologists now, like Frank Keefe and John Burns, really integrating how can our hands-on approaches, our active approaches, be um, contributors along with a talk-based approach in managing a person's condition. There is evidence that people have identified therapeutic value to touch, and George Estevez out of Malta is a great person. His work is really solid. I haven't done research in that area, but I've read the research, and indeed it does seem to have a therapeutic component to it, just the touch part. The area I do research is around contextual effects. And just so your listenership knows what a contextual effect is, this is the therapeutic interaction around the care process, that interaction between the clinician and the patient. And it can have a very beneficial effect. It can amplify the effectiveness of good treatments. So you can actually increase the effectiveness of exercise. You can increase the effectiveness of manual therapy, etc., by addressing these contextual factors. Giacomo Rosentini just published a paper in JOSPT, and it came out yesterday, and it shows that probably about 45 to 50% of the effects that we see in our interventions around manual therapy are contextual. That it's about that interaction with that patient. It's about touching them. It's about talking to them when you're doing it. Exercise has a contextual component too. Talk-based therapy is almost all contextual. So all of these things are incredibly important additional pieces to the treatment interventions we provide. And Gabrielle, is one of the reasons I say that a good manual therapist has a lot of the same skills as a good physio.
Absolutely.
They can touch on those contextual aspects, and actually they build therapeutic relationships with their patients.
Yeah, absolutely. Yeah. Has research shown, is there a particular place in manual therapy during a session? Is it better to do before or after exercise prescription, for instance?
I have not seen any research that has indicated a directionality of care. I get that question a lot, and because it would be wonderful if it did, because it could be more prescriptive, right? The one bit of research that seems to consistently pop up is there's a point of diminishing returns after 5 visits. So if you're using manual therapy and you're integrating it into your care process, about 5 visits is going to be the peak of the benefit that you're going to see from that application. And anything beyond that probably isn't going to do very much. It's going to have a very marginal effect. Now, that's on, that's average treatment effects. That's on the population as a whole. But it's certainly something that we've keyed in on when we create trials. We tend to keep our visits at 5, and because that seems to be the peak benefit. Anything above that is probably going to not really give us a whole lot more. So right around 5 visits.
Okay. All right. If you see a patient who is only used to getting manual therapy treatment and no exercise prescription, how do you motivate him to take his own health into his hands?
Great question. And indeed, we've all been there, right? We've had that patient who failed elsewhere. They don't even recognize that the care they received is probably not the optimal care. And when you try to convince them that, this strategy is a little bit different, there's a lot of give and take. There's a lot of time spent in education. And to be truthful, there's a lot of failures with that. All right. If you talk to a psychologist, they'll tell you that the success rate for talk-based therapies in education is about 31%. So most people do not succeed in that. So like your listeners, like everyone, I've had a number of instances where I've tried to talk to the patient about, we're going to change this a little bit. We're going to add these active elements to it. I'm going to prescribe these. I want you to do them at home. We're going to do them here. And that patient may not come back, or they don't do their home program, or they complain. I mean, we run into those problems all the time. So I just tell people when I educate my students, I say, just do your best. Just give them, talk them through that, build a relationship with them, tell them to give it a try. If they have certain types of pain syndromes, like nociplastic pain problems, like fibromyalgia, let them know that they're going to have a period of worsening before they actually get better because of exercise windup and a number of other components. Try to lay out to them what they can expect, and when that actually happens, maybe they buy in. But I've had a number of people who, they look for something and they will physio shop until they find it.
I like that term, physio shop. Um, Chad, what type of patients do you see in your own practice?
We will see mainly spine patients,
Mm-hmm.
but we've also had a number of trials with the shoulder, and we've had one trial of the knee. So almost always musculoskeletal. We are very interested in persistent chronic pain. We believe that is where the real talented clinicians can make a difference. Um, and so most of the time we'll put a limit of at least 3 months of pain and at least a 3 out of 10 on pain intensity before we actually see those patients.
Mm-hmm. Do you work with a team? I guess you work with a team of multidisciplinary people, psychologists, doctors,
Yep.
etc. Mm-hmm.
And again, for clarification, the patients I'm seeing are those that are in our trials that
Yes.
we have. So,
Mm-hmm.
in essence, we have a very prescriptive approach,
Yeah.
which does involve a number of individuals who function at in a given area, whether that's the psychological part of it, or the health management part of it, or the medicative part of it, or the surgical part of it. So, indeed, we have a lot of different. It's almost always interdisciplinary.
Mm-hmm. What trial are you working on at the moment?
The biggest trial we're working on right now is the SS-MEC trial, and this is a mechanisms trial. So we're looking at patients with chronic neck pain, and we are comparing an exercise-only based approach versus a manual therapy-only based approach, and we're capturing mechanisms. So mechanisms are different than clinical outcomes. Mechanisms are more of the why does the intervention work? Are we improving stiffness? Are we improving range? Are we actually improving endurance or strength or pain pressure threshold or elements like that? We're still capturing the patient reported outcomes measures, but that's a secondary measure. We're really interested in whether exercise and manual therapy really do the same thing. In other words, they have the same mechanisms, the same treatment mechanism, or are they actually different?
Mm-hmm.
Our hypothesis is they actually do the same thing, because we're starting to see that in other investigative areas like psychology. There are so many different types of psychological approaches, but actually when they're studied, they do the exact same thing mechanistically.
That's very interesting. Yeah. Mm-hmm. And in your population that you selected, are these people sedentary? Do they work from home? Do they work at a desk 8 hours in a row?
They're a little bit of everything.
Okay.
And because in two of the sites, this is three different sites that we're actually collecting this information. In two of the sites, it's actually in a clinical environment. In our site at Duke, these are individuals that we recruit who were patients that actually saw their primary care physician for neck pain. So they are individuals who would be eligible for physio. We're just not seeing them in a physiotherapy clinic. We're seeing them in our lab. So there's a little difference on that patient type, but typically they're the same type of individual you would see who has chronic neck pain, and the great variability that exists with all those patients.
Okay. Okay. So when do you hope the results will be published?
Well, we've collected 56 subjects so far. Our
Okay.
goal is 126. It's a fairly robust trial, so it's 6 months long. So it's a lot of work involved. There's a lot of data involved in it.
Mm-hmm.
So my gut says we're probably a year and a half before we actually publish the results. And most likely there'll be a primary study from it, which is the clinical trials mechanism one. And then we are going to look at some baseline factors related to success with one intervention or another. So it'll have somewhat of a moderating component to it. So we'll probably end up with two different results from that.
Okay. Good. I can't wait to see the results.
Thanks.
On a more brighter definition, I know back pain is what we mostly talk about, but neck pain is also quite a difficult subject as well. So many people come for neck pain, right?
Oh, and it's like the ugly stepchild of low back pain, right? So much money goes toward low back pain,
Yeah.
and neck pain it's not as big of a burden worldwide, but it's a huge burden. It's the second worst one out of musculoskeletal. So we're surprised at the lack of good research in that given area, especially knowing how debilitating it can be. And I'm really excited. I love working with the neck. I actually enjoy it much more than working with the back.
Mm-hmm. Yeah. I see a lot of patients, they're called digital nomads, and they work from home 12 hours in a row in front of their laptops. And
Okay,
they all
you
suffer from the same pain.
digital nomads, and I'm going to steal that because I like that term too. That's really
Yeah.
good.
They can work from anywhere in the world from the laptop.
They can, yeah. It's COVID accentuated that too, and we have the same thing. There are a lot of people who, but even socially, sometimes they come to our sessions and it's their social time. And whenever the study's over, many of them say, "I don't want to stop. I love this. I really enjoy this." And we're like, "You're done. Um,
Get
go
out.
away."
Yeah. Um, Chad, how do you see the future of manual therapy?
So I see it in the same lens that I see, what's the future of exercise prescription and what's the
Mhm.
future of psychologically informed practice. I think there are two things that we need to focus on. It's not whether the intervention is efficacious or effective. We know it is. And it's the same with exercise. We know it's effective. Same with talk-based therapies. We know it can be effective too. So I don't see us spending a lot of effort continuing to do trials where we're looking at different types of techniques or different types of exercise versus manual. I don't think we're going to need to do that moving forward. What I do think we're going to look at is for the future manual therapy is we need to know why it works. So more mechanisms trials, uh, more translational basic science studies that actually show what happens physiologically or psychologically when a manual therapy approach is applied. So how does it change the inflammatory system? How does it change a person's pain perception? So I think that's the next thing, and that's highly aligned with precision medicine. So it makes good sense to me. And the third one is just incredibly important, and we've really done a poor job on this, and primarily because it's a really hard type of study to do, but it's understanding which population is going to benefit from a particular treatment and which isn't. And that requires a moderator study to look at those treatment effect moderators at baseline that suggest a person's going to benefit from exercise but not manual therapy, or will benefit from manual therapy and not necessarily exercise, or might benefit from both. And again, it takes a really large sample size. They're very expensive to do. They have to be done right. You have to collect the right baseline factors, and often this is probably going to involve some biomarker assessment too. But I think that's the future. And I think that's going to be the future for exercise and the future for talk-based therapies too. I think those two things, the why it works and who does it work for.
Mm-hmm. Yeah. In regards to the where physiotherapists who use manual therapy, where do they stand? I'm thinking, in Western Europe, I don't know what it's like in the States, but osteopaths and chiropractors, they do a lot of manual therapy, of course. Where do you see a physio who does manual therapy in between those, like this wider spectrum of jobs and roles? Because you have an osteopath who can give exercise prescription, the same with for chiropractors and personal trainers. How do we delimit all these roles? How do we make sure that we don't have, we're all in the same pot?
I think you have described North America very well too. We're
Okay.
seeing, specifically with chiropractic and physio, they have blended to the point where it's really difficult to tell them apart. The manual therapy trained PTs and chiros, they have very similar thoughts. They prescribe similar interventions. They see people a similar amount of time. It's very, very consistent. Osteopaths in the United States are very different than those in Europe. Osteopaths in the United States are similar to medical physicians. They prescribe medications, they do surgery. They really have, there's less than 5% that still use manual therapy procedures. So even though it's taught somewhat in formal doctorate of osteopathic training, it is an area that they've abandoned. So the osteopathy that we see in Europe and in South America and some of the other places, that is not the osteopathy that you see in the United States.
Okay.
I used to have a concern that the blending of professions would lend itself to a challenge, to potentially be a turf challenge for us as physios. But we tend to be the lowest cost providers, regardless of where we are around the world. And because of either socialized medicine or the fact that the cost of medical care is so high, I think it positions us nicely to provide quality care, whether it be preventative wellness or post-injury care or post-disease care. I think it positions us well in the future, and I'm not too worried that everybody is thinking along the same lines. So I'm unconcerned about that. I just think we need to continue to be proactive as professions around the world to position ourselves so that we have a seat at the table and then we can see these patients.
Mm-hmm. Okay. In regards to the exercise prescription, you were talking about, all these other jobs who can do that. I'm also thinking about artificial intelligence as well, which will get bigger role throughout the years, right? And maybe as physiotherapists who use manual therapy will then be able to have a bigger role, a more important role, because then anyone can use artificial intelligence and it could be even more accurate than the one we could prescribe ourselves.
I 100% agree with you, by the way. And I've heard people say this previously, that a lot of what a physio does, the education part, the exercise prescription, that if someone really did their due diligence, went on Google, went on YouTube, went on ChatGPT, they could put together a treatment plan that would probably fit them quite well. Mm-hmm. What they're not going to get is the therapeutic alliance piece. They're not going to get that interactive relationship with a human, and they're not going to get manual therapy. So I have heard others say the same thing, and I think there's some merit to that. I do think there's a difference in robotic application of interventions versus the human application. So that's always going to have one leg up. But certainly one of the first things that I do is I will go use some AI component and try to increase my knowledge in a given area before I'll actually pursue a specialist or something like that. We're seeing that more and more with our patients who will come to us with really sophisticated questions or questions that are not, where they've read it in the wrong place. But it's certainly a different population than it was 20, 30 years ago.
Yes, I agree with you. Yeah. Regarding manual therapy, there's I think it's the same everywhere in the world, but we talk a lot about the solitude of people, and people feel very isolated. And when some people, not just elderly people, but also young people, they go to the physio, and it's the only interaction they have during the week, and that's it. And the rest of the time they're by themselves. So you can't replace that by artificial intelligence or by anything else, right?
You cannot. And that's why, you bring up kind of a different topic, right? That just the loneliness epidemic that we've seen, that I think was also exacerbated by COVID, and the people that have lost their social units. It's especially vulnerable in the elderly population here in the United States, especially when they're institutionalized. And it may be the highlight of their day to interact with someone who cares about them, like a PT, a physio. And those things will never, ever change. They'll always have value. And it goes back to the very first question that you asked me, what makes a good manual therapist, what makes a good physio. It's a person who can touch those areas and address those areas and make a difference in that person's life.
Mhm. Well, on these lovely words, thank you so much, Chad, for your time. It was very, very interesting exchange. And I wish you a very nice day because it's early for you.
It is. And it was my pleasure. I had a wonderful experience communicating with you. Thanks for having me on.
Thank you so much. Bye.